Hello, everyone. My presentation is basically a continuation of Amy's presentation from last time. And so I'm going to be focusing on differential diagnosis part 2, specifically for children, for diagnoses more related to mental health. Next slide. So I'm going to do a brief review of the DSM-5 criteria, mainly for any new attendees that we have and for our new cohort members. Because the DSM criteria, we're going to find when I'm reviewing the mental health conditions that there is some symptom overlap. So I thought it'd be nice to just review the criteria first before we get started with everything else. And then what I'm going to do is review mental health diagnoses that have overlapping symptoms with autism, including anxiety disorders, obsessive compulsive disorder, ADHD, trauma and stressor-related disorders, and intellectual disability. And these disorders are by no means an exhaustive list, but I figured we would just spend the time on things that I kind of pop into my mind as differentials as I'm doing my evaluations. Next slide. So really quickly, we've been talking about domain A and domain B of autism spectrum disorder criteria. And of course, domain A encompasses the social communication differences in autism, including different deficits or differences in reciprocity, deficits in nonverbal communicative behaviors, and deficits in developing and maintaining and understanding relationships, more specifically peer relationships. Next slide. And of course, there's the B criteria, which really encompasses repetitive behaviors and restricted interests, such as repetitive motor movements, speech, and use of objects, an insistence on sameness or inflexible adherence to routines or rituals, or ritualized patterns of verbal or nonverbal behavior, highly restricted and fixated interests that are abnormal in intensity or focus, and then hyper and hyporeactivity to sensory input, or unusual interests in sensory aspects of the environment. Next slide. And then, of course, specifying severity based upon how significant the symptoms are and how much the symptoms are impacting the child's functioning. So, and making sure that the symptoms are present in the early developmental period, which is really the focus of this echo. And that the disturbances are not better explained by something else, including intellectual disability, other language-based impairments, developmental delay, those kinds of things. Next slide. And of course, specifying, so this is kind of related to comorbidities related to or co-occurring conditions related to autism, such as is it with or without intellectual impairment? For our younger kids, we might just say cognitive difficulties or cognitive delay. Is it associated with language impairment? Is it associated with a known medical or genetic condition or environmental factor? And pretty much Amy covered those potential co-occurring conditions in the last presentation. And is it associated with another neurodevelopmental behavior disorder, which is kind of what I'm going to be talking about. So this kind of highlights the fact that you can have autism and you can have co-occurring conditions that look similar to autism as well to kind of complicate the picture. But also sometimes you have to think about, is this purely just a different condition that we're dealing with and it's not autism? So next slide. And of course, this is just the list. We went over this in the training about how to list the autism spectrum disorder diagnosis in terms of severity levels, whether there's intellectual impairment or cognitive impairment associated with it, accompanying language impairment, and then to list other associated comorbid diagnoses that can go along with it. So next slide. So now that we've gotten that all reviewed, so I'm bringing up the slide that Amy put in her last presentation. that really looks at the complexity of autism. I mean, there are so many potential co-occurring conditions that can go along with autism. And just to remind you that the core features of autism are related to social communication differences and the presence of repetitive behaviors and restricted interests. However, there are other diagnoses that have overlapping symptoms with these core features of autism, which is why we're doing these two differential diagnoses presentations to go over those. Go ahead, next slide. So the first set of conditions that I'm going to talk about are anxiety disorders. So with young children, we're thinking about the 2 to 3 year old children that as our primary care providers and our cohorts are going to be seeing and evaluating. I often like to say that a lot of these kids might have what I consider temperamental shyness or slow to warm up. And these types of symptoms could be precursors to the child developing an anxiety disorder later on in life. So you might hear me in part of our ECHO discussions talking about temperamental shyness, slowness to warm up, kind of early symptoms of anxiety. And these are symptoms that are certainly important to not only monitor in those kids where we do diagnose them with autism, but also kids where we're concerned about autism when they end up not getting a diagnosis, because anxiety could definitely be part of the picture that we need to monitor over time. So anxiety is, by definition, a fear of something about the world or environment that seems above and beyond what would be expected and it impairs functioning. So an anxiety disorder in particular, not necessarily anxiety. There are several different kinds of anxiety disorders. There's separation anxiety, selective mutism, specific phobia, social anxiety, panic, agoraphobia, generalized anxiety. There's a huge list of them in the DSM-5. Common differentials for autism include selective mutism, social anxiety, and generalized anxiety. The other thing to think about is, I know lots of times parents will come into an appointment saying my child has sensory issues. They seem to have sensory overload. Sensory overload is a common feature of anxiety as well. So that's why it's important to keep it on the differential. Next slide. So selective mutism. Selective mutism is basically a consistent failure to speak in social situations where there is an expectation to do so despite speaking in other situations. So this child usually has normal language and can talk and interact freely with people they know well, but it becomes an issue when they're in a situation where they don't know somebody very well. So their failure to speak is not due to a lack of knowledge. So, for example, not necessarily having like language impairment, although some kids with language issues can also have selective mutism, or just it's not due to a comfort with the spoken language. So, for example, if they're an ESL learner. The symptoms have to be present for at least 1 month, and the onset is usually before 5 years of age. And it can be associated with subtle language difficulties, like I said, as well as social anxiety, compulsiveness, and need for control. So these other kinds of anxiety symptoms that we sometimes see. So child displays appropriate social communication skills in familiar settings where they feel more comfortable. And so overlapping symptoms with autism include limited social and emotional reciprocity, deficits in nonverbal communication, and difficulties engaging with other children, and problems with transitions. But these types of symptoms seem to have a more willful, volitional refusal quality to them and are much more pronounced with unfamiliar individuals. Next slide. So another form of anxiety is social anxiety disorder, and this is a common differential that I see, at least with my older kids. So a marked fear or anxiety about one or more social situations where the individual is exposed to possible scrutiny by others. So a fear of social interactions, fear of being observed, a fear of being evaluated negatively, fear of performing, those are examples. There's a fear, an identifiable fear that it will act in a way that's negatively evaluated. And usually this fear is irrational. So fear of humiliation, rejection, like some people don't like to be observed eating, for example, or just other kind of common scenarios. And the social situations almost always provoke the fear, and it's out of proportion of what we would expect. And it occurs both with peers and adults, lasts for at least 6 months, but typical age of onset is typically mid to late childhood. But as I said before, it might manifest as temperamental shyness in younger children. So overlapping symptoms could include limited social emotional reciprocity, just because of that anxiety in social situations, deficits in nonverbal communication, difficulties engaging with other children. But these behaviors are mainly due to a fear of negative evaluation by others. It's usually irrational. Next slide. Then there's generalized anxiety disorder, which is an excessive anxiety and worry. So apprehensive expectation occurring more days than not for at least 6 months about a variety of things. And it's very difficult for the individual to control their worry. And it's usually associated with a few symptoms, including restlessness, feeling keyed up, feeling fatigued. It causes significant impairment in functioning, and it usually fully manifests in adulthood, but adults describe that they were always anxious pretty much their whole life. And there's usually themes to the worry, such as performance-based themes, fear of catastrophic events, such as weather events or something bad happening to the parents, fear of separation, illness, anxiety. And common overlapping symptoms include repetitive questioning about the fears, just for the need for reassurance, rigid routines or rituals related to the fear, such as fear of something bad happening might increase resistance to going new places, trying new foods, like fear of getting sick, for example, from the food. And then sensory overload when feeling distressed, like just feeling everything's too loud because you're already feeling very overwhelmed. Next slide. Then there's obsessive compulsive disorder. And I think this is actually a really coincidental thing that Joe is actually going to be presenting on a case where he's worried about OCD. So obsessive compulsive disorder is the presence of obsessions, compulsions, or both. So obsessions are defined by recurrent and persistent thoughts, urges, or images that are experienced at some point in time during the disturbance as intrusive or unwanted, and that most individuals it causes most individuals significant anxiety or distress. And so the individual tries to ignore it or suppress it and neutralize it through a thought or an action, usually performing a compulsion. Next slide. So I think a slide maybe was skipped. We go back one. Okay, thanks. So compulsions are defined by repetitive behaviors like hand washing, checking, ordering, or even mental acts that the child doesn't even tell you about, like counting or repeating words silently, that are performed in response to the anxiety related to the obsession. And usually these repetitive behaviors are applied very rigidly. They are intended to reduce the person's anxiety or distress. And they are usually not a realistic way to do it, though. So counting might be a compulsion as relates to fear of harming someone, or hand washing, done excessive hand washing as it relates to fear of contracting a germs or virus. Next slide. These symptoms are time consuming and they cause great distress or impairment in functioning. In children, we might see more fears of death or loved ones or illness. And usually the onset is gradual and usually does not occur prior to 4 years of age. So overlapping symptoms with autism include social withdrawal as it relates to just being consumed by the obsessions and compulsions, sensory overload, rigid adherence to routines and rituals as it relates to the obsessions. And again, all due to the need to reduce fear and anxiety related to the obsession. Next slide. So then there's other co-occurring or differential diagnoses related to neurodevelopmental functioning. So ADHD is one of them. It's a really common co-occurring disorder with autism, but also it's a common differential. So ADHD, as we know, is a persistent pattern of inattention or hyperactivity that interferes with functioning or development and is characterized by several symptoms outlined in the DSM-5. 6 or more symptoms of inattention and or hyperactivity for at least 6 months to a degree that is inconsistent with the child's developmental level and negatively impacts their functioning. And then there's different subtypes of ADHD, including a combined type related to having significant inattention as well as hyperactive impulsive symptoms. There's a predominantly inattentive type, which is more related to having issues with inattention, and then a predominantly hyperactive impulsive type, which is related mainly to having more hyperactive impulsive symptoms. Next slide. Associated features include low frustration tolerance, irritability, mood lability. There's disruptive and oppositional behavior can co-occur, especially as task demands become too effortful, and therefore the child just kind of devalues their importance because they're just too hard. And then overlapping symptoms with autism include difficulties with social and emotional reciprocity, sustained eye contact can be an issue, picking up on others' nonverbals, difficulties with peer relationships, difficulty with transitions, all typically due to having issues with sustained attention and impulse control. Next slide. Then there's trauma and stressor-related disorders. So these result from exposure to a traumatic or stressful life event, and it can manifest in many ways, including anxiety, fear, apathy, dysphoria, anger, aggression, dissociation. Examples include reactive attachment disorder, disinhibited social engagement disorder, and post-traumatic stress disorder. Next slide. And reactive attachment disorder consists of a pattern of inhibited, emotionally withdrawn behavior towards adult caregivers, usually manifested by rarely or minimally seeking comfort or responding to comfort when distressed. Likely because up to that point, the child has learned that being distressed does not provide them any comfort, or it could result in something more punitive or harmful. Must display at least 2 symptoms, including minimal social and emotional responsiveness to others, limited positive affect, episodes of unexplained irritability, sadness, or fearfulness, even when there are non-threatening interactions with adult caregivers. The child must have experienced at least one of these things as part of their history. So having a persistent lack of basic emotional needs for comfort, stimulation, and affection, repeated changes in primary caregivers that limit opportunities to form attachments, rearing in unusual settings, such as institutions with high child-to-caregiver ratios that limit the ability to form attachments. And usually the symptoms are present prior to 5 years of age. Next slide. Then there's disinhibited social engagement disorder. So they must display at least 2 symptoms, including reduced or absent reticence in approaching and interacting with unfamiliar adults, or overly familiar verbal or physical behavior, diminished or absent checking back with the adult caregiver after venturing away in an unfamiliar situation, or willingness to go off with an unfamiliar adult with minimal or no hesitation. This is not due merely to the child just being impulsive. And again, like with reactive attachment disorder, the child must have experienced something in their early history that would lead them to engage in these behaviors. Next slide. And then there's post-traumatic stress disorder, which has a lot of diagnostic criteria, but for children under 6, usually the official full diagnosis of PTSD is related to exposure to actual or threatened death, serious injury, or sexual violence, either by directly experiencing it, witnessing it, or learning about it from a loved one, like a parent or caregiver. And usually there's intrusion symptoms that occur, like memories, dreams, flashbacks, reminders, cues. And upon these intrusion symptoms, or upon kind of these reminders of the traumatic event, there may be persistent avoidance or alteration of mood or cognition. And then alterations in arousal and reactivity associated with the traumatic event. And the duration is more than 1 month and causes significant distress or impairment in functioning. Next slide. So overlapping symptoms include difficulties with social and emotional reciprocity, limited nonverbal communication, such as eye contact, language delay, repetitive play, and motor mannerisms. sensory difficulties related to the traumatic experience. So if there was like a loud sound related to the trauma, they might get really react very intensely to that loud sound. Just important to note that reactive attachment disorder and autism spectrum disorder, based upon the DSM-5, technically cannot be diagnosed together. Usually with reactive attachment disorder, if the child is in a stable and nurturing home environment, their symptoms will improve over time. One thing I want to mention is if your patient has that history of severe neglect or trauma, that this automatically would be a patient that might need more in-depth evaluation by a specialist rather than moving forward with diagnosing autism, just because of the strong overlap between reactive attachment, social inhibited social engagement disorder, and then the PTSD. These are really kind of difficult diagnoses to tease apart. So it's important maybe to refer on. So next slide. And then there's intellectual disability. So that's just defined. And with the young children, we're not going to be diagnosing intellectual disability prior to the age of 5. But for children who have cognitive delay, so basically by definition, they're significantly behind their peers in the bottom 2 percentile in terms of their cognitive functioning. And they also have impairments in multiple areas of adaptive functioning. Intellectual disability is diagnosed in the developmental period, so it's not diagnosed in adulthood. Keep in mind, though, that intellectual functioning is not stable until mid-childhood, so a diagnosis might be deferred until that time. And typically prior to that, diagnoses like global developmental delay are used to describe cognitive and other delays in children prior to the age of 5. So overlapping symptoms with autism include social and emotional reciprocity and peer relationships seeming delayed, but they are usually commensurate with cognitive level, and the child might also display some repetitive mannerisms. Next slide. And so kind of key take-home points, because of all the overlap with all the other different kinds of diagnoses, is that really trying to understand the cause and function is important when considering a differential diagnosis. And I kind of highlighted some of the potential causes of anxiety, potential causes of trauma. ADHD looks different. There are social deficits, but it's not the quality and reason for the social deficits is different. So keeping in mind that with autism, I talked earlier about kind of the lower social focused volume, in autism, the higher object focused volume, in terms of kind of what the individual with autism, what they're focusing on in their world. And versus something like irrational fears or adverse childhood events, such as anxiety or OCD or trauma, being the root cause of the social difficulties or repetitive behaviors that you're seeing. With ADHD, of course, difficulty regulating attention and inhibitory systems are the main reason behind the problematic behaviors. And then, of course, delayed development, causing kind of delay in social development as well. And keeping in mind how that's different than what we consider more divergent or atypical development that we see in autism. So bottom line is always stay curious and seek consultation when needed. I think that's it. Any questions?
Yeah, thank you so much, Elena. What a great way to close out Amy's introduction to autism diagnosis. This is something else that I think troubles most of us, is, are we missing something else that could better explain it? So thank you again.